Hello, good morning. Today I'm going to talk to you about thyrotoxicosis. So, what is the difference between hyperthyroidism and thyrotoxicosis? There's a vast difference between both, and as the definition says, hyperthyroidism means a sustained overproduction and secretion of thyroid hormone, namely T3 and T4. But thyrotoxicosis is a clinical manifestation of hypermetabolic state caused by excess of thyroid hormones, thyroxine secretion. So, as such, a biochemical parameter of T3, T4 increase alone will say as a hyperthyroid state. Uh, but this one is a clinical entity by which manifestation of the increased hormone level is manifested. That's why it's termed as thyrotoxicosis. What are the causes of hyperthyroidism? So there are many causes where we have toxic diffuse goiter, toxic nodular goiter, toxic nodule. We have Graves' disease, Plummer's disease, toxic adenoma, ectopic hormone secretion, struma ovary, pituitary adenoma, hypersecretion of TSH. All these are all causes. These are a bit rare causes, but anyway, they are all causes of hyperthyroidism, of which Graves' disease takes the most important aspect. Of course, Plummer's disease is also there. The other causes are subacute thyroiditis, which can be triggered by radiation, granulomatous disease of Desquin, postpartum period, they can go for acute thyroiditis, and Hashimoto's disease can produce a condition called Hashimoto's. Usually, Hashimoto's initially the phases of hyperthyroidism, and later on they'll go for hypothyroidism. Excess of iodine, maybe after iodine use, IV contrast, or drugs like amiodarone, that is called Jode-Basedow disease. So that also can cause some sort of a iatrogenic cause of hyperthyroidism. Excess thyroid hormone intake is called thyrotoxicosis factitia. Factitia means it is false. It's not a true type of hyperthyroidism. It is only because they have taken hormone which is not at all necessary. Let me give a little bit insight about Graves' disease. Graves' disease, described by Irish physician Dr. Robert Grave in 1835, known as Basedow's disease in Europe, more common in women. It is about 8:1 ratio and most common cause of thyrotoxicosis. What is the pathogenesis? Unlike Plummer's disease, Graves' disease has got an autoimmune basis. It has also got a genetic basis. It can be exaggerated by stress and the other environmental factors which can produce a primary thyrotoxicosis, otherwise called Graves' disease. Adam Purvis in 1956 found out that autoimmune stimuli with long-acting thyroid stimulator, a group of IgA secreted by lymphocytes, seems to be one of the cause in production of the uh, Graves' disease. It binds and activates TSHR in similar manner, albeit in a longer duration. So it is found in 95% of the patients. So clearly, an autoimmune entity has been established in case of primary thyrotoxicosis, otherwise called Graves' disease. Antibodies associated with Graves' disease are anti-nuclear antibody, anti-thyroperoxidase, anti-thyroglobulin, and antimicrosomal antibodies. Usually, clinically, we try to measure the anti-nuclear antibody or antimicrobial antibody. They are measured along with the hormone levels. Autoimmune disorders associated with Graves are, there are other disorders which are associated with Graves' disease like Addison's disease, celiac disease, diabetes mellitus type 1, myasthenia gravis, pernicious anemia, and hypokalemic periodic paralysis. All these are all associated diseases with the Graves' disease. Genetically, they found out that it's they done a monozygotic study, and concordance rate was 30 to 60% compared to dizygotic 3 to 6%. And the presence of LATs, long-acting thyroid stimulating hormone, and other suggest a genetic basis. Specific allele associated with Graves' disease are HLA-B8 and HLA-DR3. These two things you have to remember. Stress in 1925, a young woman developed a Graves' disease after attempting suicide. Major outbreak of Graves at the end of the World War II related to cortisol and catecholamine, which modulates immune status. The other environmental cause are gram-negative bacteria, Yersinia enterococci, retroviral, and cigarette smoking. They have attributed this to the development of Graves' disease. Grossly, there is a diffuse enlargement of the gland with hypervascularity. Microscopically, follicles are small and hyperplastic with columnar epithelium. Papillary projections in center of the follicle. Lymphocytic infiltration. Lymphocytic infiltration is a very important pathological change. So you can see a lot of lymphocytic follicles with large vacuoles present. Graves' disease, yes, this is a picture of pathological picture with a lot of lymphocytic infiltration with eosinophilic inclusions. What are the clinical features? The classical triad of Graves' disease are clinical THYROTOXICOSIS, exophthalmos, and goiter. Clinical features, other than what is mentioned, we have increased appetite, but loss of weight. The patient is hungry, likes to eat more, but there is a chance of lot of loss of weight. Intolerance to heat, anxiety, irritability, sweating, tired. They have also arthralgia, diarrhea, palpitation. So they have a varied features suggesting some sort of sympathetic overactivity. The other symptoms are nervousness, anxiety, heat intolerance, increased perspiration, weight loss, fatigue, muscle weakness, oligomenorrhea, increased appetite, palpitation, and diarrhea. What are the signs? The tachycardia, warm, moist skin, diffuse goiter with or without bruit, infiltrative ophthalmoplegia, infiltrative dermopathy, proximal muscle weakness, fine tremors. These are all some signs associated with hyperthyroidism. So this picture depicts how there is some sort of alopecia. There's hair loss. You have exophthalmos. You have goiter. You can have a rapid pulse, palpitations, muscle weakness, and have diarrhea, hand tremors, sweats, heat intolerance, the skin changes with some sort of a dermopathy. Okay. Thyroid ophthalmopathy occurs in 20 to 40% of Graves' disease, peculiar to Graves. More common in smokers, consists of three features: exophthalmosis, ophthalmoplegia, and chemosis. This is the stages of by which the exophthalmos develops. The final stage will be a chemosis, where there is a edema of the orbital tissue due to stimulation of fibrofatty tissue in orbit and disposition of glycon and lymphoids. This is a picture depicting the chemosis state of the eye changes. There is some sort of retroorbital edema. MRI picture showing this, and the normal anatomy and advanced Graves' disease. We can see totally a distortion in the retrobulbar area where there is a lot of deposition. There is an increased periorbital content of periorbital tissue associated with the thyroid disease. We can also grade the exophthalmos. The degree of exophthalmos dermatopathy can be graded with grade 1, 0 to 6. 0 is no sign, only signs. 2 is soft tissue involvement, proptosis, extraocular muscle involvement, corneal involvement, and sight loss. So it advanced, if you untreated, they go for a sight loss. Cause of vision loss, the involvement of the muscle, there's progressive exophthalmos produces diplopia, optic nerve compression, corneal ulceration, and vision loss. So it's attributed to the optic nerve compression later on. Graves' dermopathy is known as peritibial myxedema. It's a misnomer actually. Myxedema usually is a condition which you find in hypothyroid state, but this term was coined. It's a misnomer actually. So it occurs in hyperthyroid state in 3% of patients. Skin looks erythematous, thick, tough texture due to deposition of glycopolysaccharides in epidermis. See, the picture is very clearly seen in white skin people. There is a reddening and thickening here. Thyroid acropathy is another Bhushan. No, it is not stopped. Okay. Suddenly it went to the website. I have to come out of it. Okay, continuing our lecture. Thyroid acropathy is one of the problem of hyperthyroid state. What investigation you'll do? You'll do a thyroid function test. We investigate, we'll take thyroid stimulating hormone and then free T3 and free T4 levels. They're all increased. If you see, they're all increased and TSH level is decreased. Other investigation or radioactive iodine uptake levels can be seen is high uptake seen in Graves' disease, toxic multinodular, TSH secretion, and choriocarcinomas. Low uptake in case of thyroiditis and struma ovary metastasis. So even though there is a hyperthyroid state in both, there can be a RAA uptake and differentiate between struma ovary and other disease. This is radioactive image, iodine imaging pictures showing high uptake. The other investigation useful are USG and MRI. USG useful for nodular and cystic thyroid. An MRI can be used in case of Graves' ophthalmopathy. Modes of treatment. Basically, we have medical management with antithyroid drugs, radioactive iodine, and surgery. The disadvantage of taking medical is a high chance of recurrence and the patient compliance, agranulocytosis, idiosyncratic reaction, presence as fever, sore throat, and side effects like pruritus and dermatitis occur. The usual drug given is methimazole, 30 to 60 grams, less frequent dose, less chance of necrosis, and carbimazole is given. The drug of choice in pregnancy is propylthiouracil with arthritis and SLE-like picture. Radioactive iodine more commonly used with iodine 131. Dose is 8 to 12 microcurie orally, and overall cure rate is 90%. Expectation of euthyroid status, we expect in about 8 to 12 weeks. So 131 used as a therapeutic dose. Advantages: useful in small and moderate size goiter, useful in antithyroid drugs failure, and useful in surgery failure. Effective, inexpensive, no chance of surgery related complications. Disadvantages: teratogenicity, post treatment of hypothyroidism, ophthalmopathy will not respond, rather worsen it. So thyroid storm may develop. So these are all some not effective in adolescents. Large goiter not effective. When it comes to surgery, total thyroidectomy is done now. Originally there was subtotal thyroidectomy, but now we are the option is total or near total. It's called Hartley-Donnell procedure. Advantages for severe thyrotoxicosis: it is better to remove the gland, and patient compliance is better. The younger patients, larger gland is useful. Disadvantage: thyroid storm, surgical palsy can occur if you inadvertent injury, hypothyroidism, recurrence rate, hemorrhage. Thyroid storm, it's acute metabolic crisis due to sudden uncontrolled release of thyroxine. Basically, the treatment is rest to mild sedation, cooling injection, acetaminophen, antibiotics, lugolcidine. Propranolol IV is the main line of treatment. Tablet methimazole, but takes time. Esmolol tried immediately in IV dose. Hydrocortisone is given. It's a medical emergency anyway. Digoxin for heart failure and plasmapheresis for dialysis. Ophthalmopathy can be treated with the mild infiltrated ophthalmic, head and elevation, low salt intake, use shielded glass, and acute progressive ophthalmoplegia, you can inject IV methylprednisolone 250 milligrams for 6 weeks. And oral prednisolone can be given to reduce the retroorbital infiltrates. Sometimes retroorbital radiation has been tried in very rare cases. Severe cases, you go for surgery, orbital decompression is useful. Toxic adenoma is something which occurs in a single toxic nodule, but you see the chain of pathogenesis by which there is a receptor mutation and activation of cyclic AMP, thyroid growth occurs, development of a nodule, hypersecretion of thyroxine, inhibition of TSH. So some sort of a feedback mechanism occurs by which it grows. Iodine deficiency, production of thyroid hormone, TSH, goiter, multinodular goiter, and toxin. Investigation, we can use the same thyroid function test, radioactive iodine uptake, imaging, scan. This is a CT picture. There you can see the tumor here, compressing the trachea, displacing the esophagus. Treatment, radioactive iodine preferred because it is a single nodule. You can very well focus and give a treatment. Sometimes ethanol injection has been tried. Subtotal thyroidectomy been advocated. This is because of the inadvertent inclusion of iodine contained diet, and which can be stopped, and drugs like amiodarone and have been advocated. Excess thyroid hormone intake again is thyrotoxicosis fictitia, which can be advised, and the drug can be stopped. These are also rare varieties of struma ovary with tissues present as a teratoma somewhere. Even the ovaries, it can be there, and they can autonomously secrete thyroid hormones and produce thyrotoxicosis. Pituitary tumors can produce thyroid hormones, and the surgery, radiotherapy, and somatostatin analogs can be tried in case of pituitary adenomas. Hashimoto's thyroiditis is one form of lymphocytic thyroiditis. Hyperthyroidism is seen during initial destructive phase, followed by permanent hypothyroidism. Is the way which it presents. Other is called struma lymphomatosa, chronically lymphocytic thyroiditis. Now the term is changed as Hashimoto's thyroiditis. It is associated with other autoimmune disorders like Sjogren's disease and rheumatoid arthritis. So in pregnancy, you have what you call pregnancy and trophoblastic tumors. They can be associated with a hyperthyroid state. Thank you. So